So my due in the next few minutes is to give you a brief idea about pediatric keratoconus. So we all know that there is a structural change in the reorganization of the collagen in keratoconus. But what is so specific that the pediatric is different from adult, which needs to be discussed? Essentially, we need to understand that there is a defect in the structural reorganization of the collagen, but there are also certain behavioral differences which has to be kept in mind when you're talking about pediatric. And we all know that keratoconus is a non-inflammatory corneal ectasia, but there has been more light thrown on it that we do know that there is an increase in the inflammatory markers in the tear film. There is an increased kinetics of the cyclooxygenase. There is tenfold increase of prostaglandin PGE2. So all these direct us to think that inflammatory component has to be viewed. As far as the incidence is concerned, it is 1:2000. And when you look at the prevalence, it is 54.5 per 100,000. So the challenge when you talk about pediatric keratoconus is the presentation is very advanced at the time of diagnosis itself. In other words, there is a study which tells us that 27.8% of the young children at the time of their diagnosis are at stage 4, as against only 7.8% in adults. In other words, there is a definite indication that this is a very dynamic environment in pediatric keratoconus and the progression is faster. In fact, it has been seen that 88% of the young population have shown progression by the first year. Again, there's an androgenic preponderance more in males, and it is associated with certain genetic disorders, and also could be associated with eye rubbers, allergic eye disease, atopy. And what is seen is that there is the trigger is the mechanical rubbing and also the increase in the tear inflammatory markers, which increases the progression of keratoconus. So then we need to be very vigilant in these subset of patients. Any drop in vision, a high error of refraction, or a new onset of astigmatism, and if there is a history of eye rubbing and a significant allergic conjunctivitis and bordering on to even VKC, and if this is associated with a positive family history, we need to be absolutely concerned and definitely go on to adequate screening in these subset of patients. In fact, it is if you need to do a topographic screening, and if there is even the least bit of suspicion, the screening has to be done probably even 1 to 3 months in a younger age group, as against what you would do like 6 to 12 months in the adults. And what is the need to stress even more about VKC and keratoconus is that if there is a significant allergic conjunctivitis, there is more rubbing and more inflammation. And these are all triggers for KC to progress. So we need to become extra vigilant when there is VKC and definitely go in and hunt for a keratoconus in these eyes. And again, the challenge in a younger age group is that it is the age group itself is an independent risk factor for requiring a penetrating keratoplasty. In fact, it has been seen that between the 10 to 20 years of age group, there is fastest progression of keratoconus, and 12% of the patient between the age of 10 to 20, it has been seen that in 8-year follow-up, the need for PKP was absolute. So then, what we understand from all that has been said so far, that all demographic high-risk patients should be advised CXL irrespective of the stage and the evolution of the disease. In other words, it should be CXL at the time of diagnosis. The other thing is, if there is VKC and KC, there are certain extra challenges. There could be an associated limbal stem cell efficiency. There could be delayed wound healing and epithelial defect. So what becomes mandatory, a special word of mention is, we need to treat the VKC quite aggressively before we go on to doing cross-linking in these eyes. In other words, you need to be aggressive with topical steroid drops. We would have to add on the cyclosporin drops. We might even have to give a supratarsal steroid injection also to control the VKC, then go on to doing a cross-linking in these eyes. And we need to keep a bandage contact lens on these eyes so that do not be in a hurry to remove it on the 5th day itself. Ensure that the epithelial healing is quite adequate. And we need to also protect the limbal stem cells during irradiation with cross-linking. Now, the treatment time, there are certain issues which are very challenging, as we have understood. One is the patient compliance is going to be very poor. So when we talk about visual rehabilitation, they are not going to be very tolerant to contact lenses. And then we also know that we can't allow this keratoconus to progress because graft rejection is going to be a big challenge. So, and again, what is most important is the time, the treatment, it's very time sensitive. So we need to immediately decide to do cross-linking at the time of diagnosis. But then having said that, we can't sit back with folded arms because yes, there is stabilization of the steep K by 1 year, but the effect is not as dramatic in flattening as it is in adults because it has been seen it's because of the inherently less stiff and a more plastic corneas in this age group. And then we have to be vigilant that there is a high risk of progression despite cross-linking. And so a longer follow-up is needed in these young patients who are cross-linked. It has been seen that progression has occurred even 3 to 4 to 5 years after the initial cross-linking. So what is the message here is we need to follow up these patients even up to late 20s or early 30s till the natural period of stabilization of the keratoconus as a disease process. So where is the role of transepithelial cross-linking? We all know it's less effective, that epithelium itself is a barrier to the penetration of riboflavin. You get a superficial demarcation line and all of it is something familiar to us. But then if the epithelium, the healing itself is going to be delayed in a severe VKC, and if the child is a very habitual eye rubber and you wonder whether there's a risk of infection, if the cornea is thinner than 400, so then we may have to do a transepithelial cross-linking in this very small subset of patients, and be prepared that you would have to repeat cross-linking in case of progression. The other word of caution is that progression has been seen in 16.7% of these patients if the pre-op CCT was more than 450, but it went up to 47.6% if the pre-op CCT was less than 450. In other words, thinner cornea represent a graver corneal pathology and need to be treated with great attention. It has also been seen that the cone location is a determinant about the progression of the disease. Like eccentric cones have a higher K reading even after cross-linking. This has been seen because the peripheral cones, the obliquely incident light rays are not as effective as the direct irradiation on the central cones. So progression has been seen as early as 2 years. So then comes the visual rehabilitation. All of this is what is done in adults too. But we have to keep in mind that the contact lens toleration is poor in pediatric. As far as the intacs is concerned, intacs definitely, I cannot say that there is this particular age group after which only we do intacs. If you're confident about the results of the treatment and the indications continue to be same even in pediatric, and of course, the centered cones would do better and the peripheral corneal thickness should be 450 at least in 6 millimeter zone. Topo-guided PRK in pediatrics is a controversial issue. Maybe the person is nearer to 18 and a very early keratoconus, you're going to cross-link, he has a minimal refractive error, you would go ahead and treat. Then, of course, phakic IOS, I would definitely wait till the patient is well over 18 years and go ahead and treat the anisometropia. The final frontier is, of course, that the patient that comes to you at advanced stage, you know PK or a DALC is a treatment, and we do understand the DALC is going to be better than a PK. But what we need to keep in mind is these eyes, the scleral rigidity of these eyes are lower. There is going to be a more of a fibrin response in these eyes, and there's going to be a positive chest pressure. So the surgeons have to be definitely have an extra vigil when you're operating on a patient with pediatric keratoconus. So in other words, just a very bird's eye view, what we need to go back understanding that it needs a very stringent management specific to the disease status, and a very close follow-up is mandatory in this age group. Thank you very much.
Thank you, madam. There are a couple of questions. One is, how early have you done a cross-linking? I mean, what is the youngest age in which you have done a cross-linking? And second is, if the child has active VKC, how long a quiet period would you want to allow before you do essays?
I think we would have cross-linked earliest 8 or 9 years. The awareness is a lot more, so we do diagnose patients much earlier on and we do a screening. And VKC has to be definitely treated aggressively, as I said, like enough for topical steroid drops, and if it's very severe GPC, then you have to give the supratarsal injection, and all of which was beautifully alluded by Dr. Dipti. And once the eye comes to a quieter phase, then we would go on to do cross-linking. And I would would like to do the standard cross-linking because that is most effective. And as I had earlier said, I would like to leave the bandage contact lens for a longer period till the epithelium gets completely healed. And transepithelial is for a very small subset of very severe vernal conjunctivitis. But when you talk of limbal stem cell deficiencies, some of these patients would have corneal scarring and all that, and that itself is going to be a sort of prevent the progression of keratoconus in these eyes. So I think you whiten the eye and go ahead and cross-link.
Any comments from the expert panel, other speakers? Comments or questions?
I think one more where probably Dr. Chitra has not touched upon, they do very well with RGP lenses in children who are not very severely keratoconus. So I think rigid gas permeable lenses have equal or as good results in the initial phases at least. I don't know. I'm not a cornea person, but children whom I have fitted with RGP lenses have done spectacularly well as far as the vision is concerned. Sometimes children are diagnosed with keratoconus. Cross-linking is done, but rehabilitation part, probably they do better. Despite cross-linking, they do better with RGP lenses than with glasses.
Definitely.
Dr. Chitra, what do you say for that?
Definitely cross-linking. I was more stressing on cross-linking at the time of diagnosis, but visual rehabilitation is very, very important, and contact lens is the mainstay. By that time, Mr. Sunil had said 60 seconds left, so I caught a fast train. That's all. So contact lens.
Would you say, no, after cross-linking also, would you fit them with a RGP lens? Or yes, definitely.
Intacs and all are for more severe cases of keratoconus only.